Hi, this is Oshaya Bali, and this talk is going to be about empowering evidence-based medicine with semantic data analysis. Before we jump right to the point, let me give you a brief introduction of ourselves. B2I Healthcare is a software company specialized in healthcare information standards, information exchange, and analytics. We have a branded and recognized product line called Snowall. The Snowall technology family is deployed in over 3,000 locations worldwide. Our customers include governments, standard bodies, and universities. This presentation will introduce the youngest member of the Snowall product family, Snowall MQ. MQ stands for Meaningful Query, and Snowall MQ is an online platform for running semantic queries on a number of healthcare terminologies and ontologies. It is a big data electronic health record store, scalable to hundreds of millions of patient records. It includes a patient cohort builder using semantic criteria, and it is also an electronic health record analytics tool, allowing statistical processing of the patient data. So why are electronic patient records so important for us? Why do we think there is value in them? Societies, especially in the Western countries, are facing the problem of aging populations. This means a rise in both age and lifestyle-related diseases. These diseases are typically chronic diseases that require complex treatments, meaning that multiple care units or multiple care providers are involved in the treatment. These care units need to be able to communicate with each other, to exchange information seamlessly. The use of proper standards is essential for this communication, and we'll get back to this on the next slide. As the communication is done electronically, the tendency is that more and more patient data is created and stored. This data represents value as it includes the clinical history, and depending on the standards in use, additional clinical information can be inferred. This is the type of information that can serve as the basis for evidence-based medicine, where existing experiences and evidences guide and support new clinical decisions. So let me have a few words about standards. I'm not going to cover information modeling standards now. These are the ones that tell you how to structure your information that you're exchanging. Clinical terminologies provide the content for the clinical records, where the diagnosis codes, the procedures, medications, laboratory results are all encoded to a standard code and label. These terminologies can be simple classifications. However, ontologies that are widely used in different domains for knowledge representation allow more powerful information retrieval. SNOMED-CT is the largest biomedical ontology in the world, covering the entire clinical domain from body structures to substances, with clinically validated meanings attached to each concept. If you take a look at the picture, this is the SNOMED-CT ontological representation of a very simple clinical concept, the fracture of femur. Of course, it has an associated code and a label, or more labels where needed, and as an ontology, it has semantic relationships to other clinical meanings, telling us the location of this disorder, which is the bone structure of femur, from where we can infer that it is in the leg structure, and the associated morphology is another semantic relationship that connects the fracture of femur with the morphological abnormality of fracture, and this allows us to draw other inferences related to the morphological structures. These inferences allow grouping diseases by their meanings instead of predefined categories, just like in a classification system, allowing the creation of semantically defined disease groups. I prepared a practical example to demonstrate how these standards help us to retrieve information from electronic patient data. Imagine that you're a clinician and you're treating a patient with a severe case of chronic rheumatoid arthritis. This patient has been under clinical control with chronic obstructive pulmonary disease, COPD, for quite some time already, making him prone to other pulmonary diseases like infective pneumonia. Rheumatoid arthritis, being an autoimmune disease, can be debilitating, so you're eager to prescribe the most modern and also the safest available medication. Your patient has already started on methotrexate, a first-line medication used to treat rheumatoid arthritis and other autoimmune diseases. However, the results are not satisfactory. You are considering changing to a tumor necrosis factor (TNF) inhibitor, a more expensive biological therapy for rheumatoid arthritis, but you need to understand the risks associated with this change. As you're performing in the spirit of evidence-based medicine, you're doing extensive research on clinical papers about each medication. Your main concern is that each of these medications suppress the immune system, increasing the risk of infective diseases, and the lung infection could be fatal for a patient who is already prone to pulmonary diseases. Unfortunately, none of the research papers cover patients with the special case of both COPD or other chronic bronchial disease and an autoimmune disorder. So how will you make the right choice on which therapy to go with? You articulate your question, and the question is, which medication offers lower relative risk for infective pneumonia for patients with a similar medical history as yours, so with both COPD and an autoimmune disease like rheumatoid arthritis? Using SNOWAL MQ, this question can be answered in 3 simple steps. Firstly, you need to select all the diagnosis codes that are of interest. Find all the disorders in your clinical terminology that are similar to COPD, so patients with similar conditions can also be examined. Instead of having to look up all these disorders manually, you can define a semantic search criteria where you're retrieving all diseases that have the similar attributes that have similar attributes to COPD. So in this case, you're looking up chronic diseases that are located in the bronchial structure and that are associated with a morphological abnormality of some sort of narrowing. So this is how you get the list of diseases that you'd like to match your patient records against. The second step is to build patient cohorts of the patients that have the same clinical history as yours and took either of the medications. You're going to examine the increase of the infective pneumonia occurrences after the medication intake. The result of this exercise is 2 patient cohorts that can be analyzed with simple statistical methods. It is possible to view a single patient record to understand more about additional clinical conditions and broaden or tighten the search criteria if necessary. The top line displays the diagnosis codes, the middle line is the medication, the continuous line represents a longer exposure, and the bottom line shows the laboratory procedures, all displayed on a timeline. The third and final step is the statistical processing with the use of semantic notebooks. This notebook functionality helps with the easy and more complex statistical analysis, whether it is only a descriptive chart about the data or a more thorough statistical comparison. Notebooks help you to summarize and visualize the findings made by inspecting patient cohorts and to continue analytics on them. The analytic process runs on a fast big data platform. Statistics can be defined in the languages R or Scala. For our particular question, the answer is visible and visualized on this chart. The relative increase of infective pneumonia occurrences after the medication intake was negative for those who were on the methotrexate therapy, whereas it was over 1% for those who were on a TNF inhibitor therapy. So now you have an exact view and a good understanding on the risks that are involved, and based on the severity of this autoimmune disease you can decide whether you would like to take this risk that comes with the more effective medication. This informed decision will help you to find the safest treatments that are available. What are the conclusions here? We have learned that by using ontologies for encoding medical records, a large amount of clinical knowledge is encapsulated that can be utilized later. Semantic retrieval of the diagnostic codes allows on-the-fly creation of certain disease groups. The patient cohort builder evaluates the electronic health records against these disease groups. Combined with any demographic or temporal criteria, we didn't see an example for this really. And it returns real-time results while the analytics module allows statistical processing and report creation. So from the time you articulate your question to the point that you have the evidences you need to make your decision, drawn from millions of patient records, you only need to spend a couple of minutes for putting together these queries. SnowMQ with SNOMED City makes it possible. Thank you for your attention. With any questions, please email us at info@b2i.sg. To try SnowMQ for free, please visit mq.b2i.sg. Goodbye.